Thank you for tuning into this presentation as part of our Women's Health Week series. I'm Dr. Susan McSweeney and I'm a GP who is passionate about women's health. Today I'll be talking to you about pelvic floor and other changes in menopause. I really strongly believe in empowering women with the most up-to-date and evidence-based knowledge so that they can make informed choices about their own health. I hope this talk will help you in your journey to better health and well-being. As part of this talk, I'll be covering the definition of menopause and in particular, what happens to your pelvic floor and pelvic organs during this great transition period. More importantly, I'll be talking to you about what you can do about these troublesome symptoms. And lastly, I'll touch on a novel new non-hormonal treatment called vaginal laser. So the actual definition of menopause is the final menstrual period. This typically occurs between the ages of 45 and 55 for most women. Perimenopause is the name we give to the years leading up to this final period. Sometimes when we discuss menopausal symptoms, we use the terms interchangeably. Symptoms can last between 4 to 8 years on average, but for many women, it lasts for a lot longer. It's a time of great hormonal fluctuations as well. Estrogen, progesterone, as well as male hormones are all fluctuating with a general downward trend. That is, they're all decreasing during this time. This is a slide I've taken from the medical journal Nature. I really just wanted to show you how menopause isn't just one symptom. It actually affects many different parts of your body, from the central nervous system to your metabolism, to the skin, to your joints, and sexual function. So menopause symptoms are actually really common. Did you know that 75% of women will experience vasomotor symptoms? So vasomotor symptoms are typically called hot flushes, as illustrated in this cartoon. Many of you may relate to this. It may be snowing outside, but when you get a hot flush, it feels like your body is on fire. The other fact that a lot of my patients are surprised by is that menopause symptoms unfortunately can last a long time. Some of these studies that were done recently in the US showed that 12% of women experience these symptoms 11 to 12 years after menopause, so after that final period. In a recent survey, a third of them were still experiencing symptoms between the ages of 65 and 79. So I'm going to talk a little bit more about how the pelvic floor is affected in menopause. But before we get to that, I thought I'd just illustrate to you what the pelvic floor actually consists of. So this is a cross-section illustrating the muscles of the pelvic floor. If you imagine that this is a person and the legs are up there, and we're looking at her from the bottom up. So just to orientate you, this is the anus. This is the vagina, the urethra where the urine comes out of, and this is the clitoris. So I just wanted to demonstrate to you with this slide that when we're talking about the pelvic floor, it isn't just one entity. It's actually a complex group of many muscles that make up the pelvic floor. So looking at the pelvic floor side on, this is another cross section, we can see that it's actually a hammock-like structure. So from the front, it attaches to your pubic bone, and at the back, it attaches to your coccyx or your tailbone. This hammock-like or bowl-shaped group of muscles performs a very important function. It holds up all of the organs in your pelvic cavity, including the bowel, the uterus, and the bladder. Unfortunately, many factors can weaken these pelvic floor muscles. For women, pregnancy and having a vaginal birth are particular risk factors. And in terms of childbirth, if you had a large baby, birth trauma, or had a forceps delivery, this could especially put you at risk. Other factors include being overweight or experiencing chronic cough or chronic constipation, and doing lots of high impact activities such as running, jumping, and weightlifting. And last but not least, we mustn't forget menopause as a big risk factor. So menopause leads to a decrease in estrogen, which helps to maintain healthy skin elasticity, particularly in the muscles and the ligaments of the pelvic floor. Without it, it can cause a weakening of these structures that can lead to prolapse. So I'm going to talk to you a little bit about prolapse. This is a cross-section of normal pelvic organs which are in their original position. To orientate you, this is looking at the woman's side on. This is the anus and the rectum. This is the uterus and the vagina. This is the bladder and urethra where the urine comes out. And this is a pubic bone and the coccyx or tailbone. The best way to describe or define prolapse is the shifting of these pelvic organs from their original position due to a weakness or defect in the muscles and ligaments that hold them up. A picture says 1,000 words, so I'm going to show you a few illustrations of what I mean by prolapse. The first one I'm going to show you is a bladder prolapse, otherwise known as a cystocele. As you can see, a portion of the bladder has prolapsed into the front wall of the vagina. Unfortunately, this can cause a lot of uncomfortable urinary symptoms for the woman and also a feeling of having a bulge in the vagina. We can actually see this when we do examinations. So similarly, the rectum can also prolapse into the vagina, as is illustrated in this image. This is also called a rectocele. This can cause problems of defecation for the woman, and again we can see this when we examine them. So the uterus, which is supposed to sit nice and high up here in the pelvis, can also prolapse into the vagina. This can be particularly uncomfortable, and when we examine the woman, we can actually see the uterus protruding. So those images are quite confronting, aren't they? And I'm sure you're all crossing your legs by now, and you'll be very much wanting to know what you can do about this. Obviously, surgery is an option as a treatment. That is a very big topic of which I won't be covering here. I'll be covering some conservative non-surgical management options for you. So a very important part of non-surgical management of prolapse is pelvic floor exercises. And this is where often prevention is better than a cure. So it's actually never too early to start exercising your pelvic floor. But also it's never too late either. As you've seen before, the pelvic floor is a large group of muscles, and like any muscle, exercise needs to be done regularly. And because it's a muscle you can't see or easily feel, seeing a good pelvic floor physiotherapist is often critical in getting started and getting it right. We now also have these pelvic floor exercise aids. So this is one that we have at the clinic, and I'll just show you another. This is called the Peri Coach, which we're actually giving away as part of a competition with our Women's Health Week presentation series. Another non-surgical option for prolapse is pessaries. I do feel like they're underutilized. Many women simply don't know they exist. They come in all different shapes and sizes, and essentially what they're doing is providing support for your weakened pelvic floor to help hold up those pelvic organs that have prolapsed. This is one shape called a gel horn pessary. It's a space occupying pessary because it does take up a little bit of space in the vagina. So this is a slightly different shaped pessary called a donut pessary. As you can see, it doesn't take up any room in the vagina, so it's not space occupying. And you can leave it in during intercourse if you wish. I'm going to talk about another unpleasant part of menopause, which many of my patients find difficult to talk about. We call these symptoms genitourinary syndrome of menopause, and it's very understandable why women shy away from discussing these symptoms. There are three main parts to it. First, vaginal dryness, which is often accompanied by itching and burning, painful intercourse, which I find leads to a lot of women stopping having sex earlier than they would have otherwise liked. And also urinary symptoms such as recurrent infection and incontinence, which can really affect a woman's confidence and ability to do normal activities. If those symptoms are sounding familiar to you, you are not alone. They're very common. Half of women will experience some of these symptoms or all of these symptoms. Half will actually report their symptoms to be moderate to severe. And unfortunately, unlike many other symptoms of menopause, these types of symptoms don't tend to get better with time. So why does this happen? We know that estrogen becomes low during menopause, and estrogen supports healthy skin. The other thing that occurs is a reduction in blood flow. Both of these factors lead to a thinning of the normal vaginal mucosa, which then becomes very fragile and easily damaged. The other thing that happens is that there is an increase in the pH, which then causes a lack of normal bacteria. This then leads to infections both inside the vagina and also in the urinary tract. Anatomically, interestingly, the vagina itself also becomes more narrow and shortens, which of course can make sex uncomfortable. The nervous system around this time also changes, which controls normal urination, and the incorrect signaling can lead to things like urgency and incontinence. One of the treatments we have for these symptoms is topical estrogen. It makes sense that since low estrogen is one of the causes, that replacement will help with these symptoms. There are two products available in Australia, Ovestin and Vegifem, which are directly applied to the vagina. It is very safe and effective and improves many of the troublesome symptoms we discussed earlier. One little downside is that it does need to be applied regularly and continually for the improvement to be maintained, and sometimes this can get cumbersome, and the cream can sometimes get a little bit messy. So I'll talk to you a little bit about vaginal laser, which is a novel treatment available to help alleviate some of these symptoms. So laser technology has been used in gynecological surgery since the 1970s, and of course it's been widely used in dermatology to help a variety of conditions from skin rejuvenation to acne to scarring. In 2009, two Italian doctors, a dermatologist and a gynecologist, wanted to recreate a machine that can be used in the vulval and vaginal area, specifically targeted to treat these menopausal symptoms. So this machine shown on the right is where all the original studies were done on, and essentially what it does is deposit laser energy into the skin to stimulate cellular regeneration. It helps to reverse some of the aging process so that the skin is more like premenopausal skin. So I'll just show you a short video that demonstrates the procedure of the vaginal laser. So this is taken from the MonaLisa touch machine, which we have at the clinic. So we do this by first applying some topical anesthetic to the vulval area, and then we insert the probe all the way into the vagina. So patients often worry whether this can be painful, and they're pleasantly surprised that it's virtually painless. So as we're withdrawing the probe, we then apply the laser dots into the vagina skin, and it's done in a 360 ring-like fashion. And as you can see, this is sort of an internal animation of what's going on inside. And the ring is demonstrating the laser energy. So it's actually applied in little dots. That's very, very tiny. So it's actually in microns or micrometers. And these fractionated CO2 laser dots then penetrate quite superficially, so it's not very deep at all. Demonstrates here deposition of the energy into the skin. And then what happens after that is that the skin then produces a lot of growth factors and activates growth of fibroblasts and synthesis of something called collagen, which of course helps to maintain the elasticity of the skin. So I'll just stop that there because it goes on for a little bit. So the current regimen of treatments is 3 treatments 4 to 6 weeks apart, and on average a top-up annually. So the treatment itself only takes about 10 to 15 minutes, and there's not really any downtime. You can pretty much return to normal activity fairly quickly. We do find, however, sometimes if you have very severe symptoms, such as in breast cancer patients, more treatments may be needed to get the effect that you want. Certainly, the studies to date have shown that it is effective. I'll just show you the image from one of the original studies done. This is a biopsy before treatment, and this is a biopsy after treatment. So this is from postmenopausal vaginal skin. Before treatment, you can see that the surface layer is quite thin, and then post-treatment, this is after one laser therapy, 2 months down the track from the treatment, the skin surface layer is a lot thicker and much more well defined. This is more like premenopausal vaginal skin. So certainly more studies and research is needed to guide its use, and there is actually currently a study being done in Australia at the Royal Hospital for Women. So because it's a new treatment, there are some important considerations. Patient selection is really important, and so is having an experienced practitioner. It's important that the doctor you see is experienced in using this technology so they can do a proper assessment on whether it's actually going to help your symptoms. There hasn't been any major safety concerns in the observational studies done to date. However, there has been some concern in case reports in the US. Part of the problem is that a lot of untrained people using machines that actually haven't been studied at all are using this technology in this very vulnerable part of the body. Some people who use this machine aren't even doctors and are cosmeticians or just laser clinics. So it's really important that you go to the right people. Because it's currently unfunded, the cost can be a real barrier to accessing this treatment. So I really welcome and look forward to further research and regulation to help guide its use so that more women can benefit from this treatment. So menopause is a time of great change in a woman's life. So many parts of your body is affected. And today we've specifically focused on the genitourinary tract, pelvic floor, and pelvic organs. I hope you can see now that it's never too early to start some preventive strategies such as pelvic floor exercises. But now you also know that if you do suffer these symptoms, there are some very effective ways to help you to still live a very full life. Here's a list of my references that I used for my talk in case you're interested. So thank you again for joining me in this talk. I really hope that it has encouraged you to talk about your problems with your peers and in particular with your medical practitioners so that they can help you treat your symptoms and help you live a more satisfying and fuller life.